were always taken for them. They were involved in live surgery workshops. They were trained hands-on in the art and craft of laparoscopic surgery. So it was a pleasurable moment for me as well as people who are joining these training programs and getting themselves enriched, as well as I was also getting enriched in this academic exercise. So gradually requests from many parts of the world started coming in to join this training program and the academic platform. So it was always a pleasure training the young minds and surgical colleagues in laparoscopic surgery from across the country and from SAR countries also. So people who are getting trained, after completion of the training, they were all awarded a bilateral knowledge sharing and knowledge enriching experience. The young brigades were enjoying all these academic ventures built, and in 2018 I switched over to AIIMS Bhubaneswar. The same passion for teaching and training continued there with the opening of the Advanced Laparoscopic Surgery Training Center at AIIMS Bhubaneswar and EDF courses in AIIMS. Then came the pandemic, and after the pandemic, I thought of starting a weekly academic event on laparoscopic surgery in the month of June. I continued it for 2-3 months, then started chipping in colleagues from across the country and many parts of the world. They accepted my request, they joined in, shared their wisdom, and people were all happy. So Surgical Academia is now having a Facebook page of 8 members from 14-15 countries. And the Surgical Academia WhatsApp group has got members who are who's who in surgery and surgical gastroenterology from across the world and from across the country. So welcome to this Surgical Academia, which is no more a platform, it's a surgical educational movement. Welcome to.
So in this connection, in fact, today's speaker will be Dr. P Jagannath. P stands for Aleppo. He is the chairman of and Department of Surgical Oncology in Lilavati Hospital in Mumbai and Chief of GI Oncology in SL Raheja in Mumbai. He is the past president of International Hepatopancreatico-Biliary Association. And I'm proud to introduce him that he is the only Indian who has honored this coveted post of President International Hepatopancreatic Biliary Association. Probably this is a big honor for any Indian apart from other countries. So Dr. Jagannath was initially was a professor and head in the GI oncology in Tata Memorial Hospital, from where he left and joined into the corporate sector, and he is presently in Lilavati Hospital, and lot many honors in his name. So that run into pages. I'll just give some of the hints, some just glimpses of some of the accolades that he has got in the international platform. He is a passionate music lover, and in fact, just before the starting of the webinar, we were talking about his father, and it's good to see him with his father, who is a retired professor of pharmacology. He's 93-year-old, and in fact, few days before he had his birthday. So I think please convey our best wishes to sir. In fact, Prasanna Reddy sir was his student, as he was just telling before this. So my association with Dr. Jagannath dates back to 2008 when the first World Congress of ISPBA was held in India. And after that, I had an opportunity of coming to this IHPBA, where I became closer to him. And I became closest to him in this 2014 World Congress, where I had the opportunity of presenting a plenary session. I do not know if you remember, Dr. Jagannath, that before I went for my talk, you just made a thumbs up. That was so encouraging that another senior faculty encouraging me before I go for my plenary talk in World Congress in Seoul. That was the place where we were really closest to each other. And this continued, and one of these webinars, last time he had talked on these Whipples. And the next week, we'll be having another interesting webinar. Is a big fight between open and laparoscopic surgery in groin hernia. Professor Mohan Dasarda, who is a die-hard open surgeon who is probably the only Indian whose name is now in hernia surgery in different textbook, and he will be talking on open surgery. Dr. Bhatia will be talking on laparoscopic surgery, and I will be moderating both of them and moderating this fight. So again, next time we'll be having this good session on this hernia. So without wasting much time, may I now invite Dr. Jagannath to start his talk. I am just stop sharing this screen. Sir, could you please share your screen?
Yeah. Thank you so much, Manas. You see, it's a matter of great pride when any Indian starts presenting on a plenary session. Plenary session means that you're the best of best in the world. So I feel extremely happy that for the last 4 world congresses, India has the maximum number of papers, academic papers, and also the participation. So please keep up the academic out, because that's how the country is known. And then we need to continue this. You have started a great activity. Let me tell you the number of people who have joined you, Manas, which also means that all the people are willing to teach and train the residents particularly. So that's the reason why they're all with you and they're supporting you. And you have done it without I always believe that individuals matter, and you don't have to have a big association platform with you. And if you are a good person, good individual, committed, you'll automatically people join you up. So keep up the good work. But at this time, I challenged Manas. I said, Manas, webinars are becoming boring. You know, you don't even know whether the people have signed in. As I told you that my grandson signs in and walks out. So I said, why can't we have something more interactive? And fortunately for us, Google has just released in, I think, October last week or so, the Google Suite, which is now being used so that you can poll. And we can also tell, we can kind of have some kind of an interaction. It will be very, very encouraging for both of us. And it's so good to see so many senior colleagues here. So without much of a time, I'll start my presentation. It'll be a little different. It'll be more interactive, hopefully this time. It'll be on one of the, I would say, the most difficult GI oncological procedure. You see, when we went to Japan, I said Whipple's. They said no, Whipple's is like, it's a just ordinary car, and HILAR cholangiocarcinoma is a Ferrari of GI surgery. And then I realized that as I went in, it is really one of the very complex procedures. Now let's start this particular session with a bit of a fun. We had a very interesting polls. Polls have been extremely important. Even now, you find that the American victory is still contested, but most important thing is people have polled. So we just wanted to have this as a trial for all of us, all of you here, of running the first poll as to find out what's the kind of a spectrum of audience we have, so that we can kind of tailor and modify the presentation accordingly. So Manas will just run a quick.
I'll just written as ABCD.
Just put it as ABCD. A being residents who are Indian, B residents overseas, C are consultants who are Indian, and C consultants outside. And Manas will read out what's the kind of
I think
spectrum.
So all of you please respond to this poll before this complex surgical procedure starts in an easier hand. I mean, let's enjoy this surgical feast that will be the next 1 hour. But before that, just let's have an idea how is the audience spectrum. Resident Indian, consultant Indians, resident overseas, and consultants overseas. You just click ABCD.
It's interesting. You can actually see the poll being active.
Yes, it's coming up. I mean, people have started giving in.
Yeah. Might take a little time, but it's fine. Polls take time, results take even longer time.
Sure.
I think Bihar is putting out their results much faster than United States. So
125 people.
So we have 125 people. Out of them, there are 45 overseas consultants. There are 40 overseas residents, and the rest are all Indian consultants and residents. And amongst them, a majority of Indian consultants are there. There are residents also of equal proportion. It's
great.
a good.
Yeah, it's a very good mix. Very good mix. Very encouraging mix. So we can go ahead further. Now, I think this is, it might look very basic. You know, what is this Klatskin tumor, which we are talking about today? Is it a tumor of the common bile duct, a tumor of biliary bifurcation, or a tumor of intrahepatic bile ducts? I think now that you have polled once, we will kind of go over this very quickly. Though it is classically described as a tumor of the biliary bifurcation, we also should understand that the tumor can extend down into the common bile duct and also can extend up into the intrahepatic bile ducts. But this is a tumor which basically starts at the hilum. Our own journey, as Manash has said, started with the World Congress, where you can see here Yuji Nimura and Andre Bismuth, two of the greatest surgeons who have given what all the future path of this hilar cholangiocarcinoma for staging as well as for surgery. So we are very fortunate, and from this, our interest and our journey started. Now, who is this Klatskin? It's very interesting to know that Klatskin actually is a physician in Yale University. And you know, many of the Indians, for those overseas colleagues, whenever somebody has some connection with India, like if you say Kamala Harris, he says, oh, he is from India. You know, we are the ones who have given world Kamala Harris. So we can also say that while he was in Calcutta during World War II, he saw a lot of amoebic abscesses and other liver diseases and went back, and then he started doing liver biopsies and improvised the needles. And finally, he studied nearly 50,000 liver biopsies, which is something extraordinary. And he had a great pathology colleague, which is very important, who described this small adenocarcinoma involving the porta hepatis in just 13 cases. He also says that, you know, I'm not the first one who is to report this. It has been reported even earlier, but this is what I find in 13 cases. From that point onwards, people have started quoting his article, and then it started becoming a Klatskin's tumor. But what is hilum? Hilum just means a point. It's just a point of entry of vascular structures. What's in the hilum? Claude Cuno, he says nothing is in the hilum. So, in fact, if you really look at it, when you start mobilizing the base of the segment 4, you find that the hilar structures, both the right and left systems, leave and enter the liver, and there's really nothing at hilum. So what is actually the correct terminology is a perihilar cholangiocarcinoma, which is around the hilum, which is the right terminology currently being used. Now, why is it so important? That if you look at this, you find that within this small area of the hilum, the three important structures, the portal vein, the bile duct, and the hepatic artery go together into a condensation of the Glisonian pedicle. And because of this proximity to the vascular structures, these very small tumors infiltrate the vessels very quickly, and that is the complexity which is involved in surgical management. Now, these arising from the biliary epithelium, it can be at the bifurcation going into right and left ducts, and which is very, very important that they involve the vascular structures quite early. They also produce obstructive jaundice early because it's like a very small, narrow bile duct at that point of. So, like a periampullary tumor, it can also produce jaundice early, and these do present with jaundice in most of the situations. What's also an important thing to see in the anatomical details is the posterior relation to the hilum. The posterior relation to the hilum is formed by the caudate lobe. In fact, the caudate lobe is literally like a bed on which the entire hilum rests. The importance of this has been recognized by Professor Nimura, saying that the tumor spread along the caudate lobe ducts And if we do not remove the caudate lobe, there is a likely chance of a local recurrence for these tumors. So that is the important issue. That's a very small area, so you have very small margin for error. And because the anatomical, it's a very closed area, the involvement of the vascular structures is very early. We must also remember that the bile ducts are not in the same pattern as the QNO segments. It can be a differential drainage from the bile ducts. So bile ducts, though major anatomical follow the portal pedicle, but there can be a lot of variations as far as the bile duct anatomy is concerned. Now let's talk into the different issues which we are going to talk today. One is about resectability and staging. What's the role of preoperative drainage? What is the kind of issues in the surgery, and what are the likely post-operative problems? I'll try and segment these things into different areas. I always acknowledge the great contributions of Professor Nimura here in Nagoya, and the time I spent with him was the most productive time. It was not even in Memorial Sloan Kettering, but it was in Nagoya that I learned the maximum amount of liver anatomy and liver surgery. And what did I really learn? This is what I want to tell the junior colleagues very clearly, is that the planning, the meticulous planning, next day morning is a surgery at between 10 and 11 in the night. We are discussing about the surgery and different aspects of what is to be done the next day morning. As per the plan, a carefully executed surgery is very, very important. And after that, again at night, the entire team meets and documents the procedure really. There is no joke that they are in the department till midnight, 12 o'clock. And most of them actually sleep in the department. But all this happens because of commitment to excellence. It is unfortunate that really this kind of an excellence has not been replicated across the world. You have hundreds of people who do a Whipple's procedure, and even more doing a hepatectomy for a colorectal metastasis, but you really have just a handful of people who do HILAR cholangiocarcinoma surgery because it's that commitment.
I think your screen sharing need to be done once again.
Okay.
Somebody has pressed the present now. You just share it and pin it so that nobody else can have a presentation in between.
Now, okay?
No, it's not coming now. Yeah, it's coming now.
Okay?
Yeah.
Are you okay?
Yeah, it need to be pinned here. Yeah. Yeah, that's fine.
Now, what's a clear message which Professor Nimura said is radical surgery is the only hope for long-term survival.
I think there was some.
Again, problem? Are you okay?
Yeah, it's fine now.
Yeah. Now, and how do you plan a surgery is by accurate anatomical staging. This is very important. So staging has to be done before intervention. This is a most important message. I think every surgeon who is here has to convey to our gastroenterology and IR colleagues that please stage the disease before you put in the stents. This is a one single message we must convey our colleagues. What is the staging involves is one is the evaluation of the bile duct. How much is the tumor spread proximally and distally? What's the kind of vascular involvement? Is there any loco-regional or distant spread? The biliary involvement is very, very important, particularly the proximal side. Very important. And the portal vein involvement, right or left. I want to make it simple that there are only literally two procedures which you need to know as far as HILAR cholangiocarcinoma is concerned. The third one is more difficult, but it is also can be done. So that's about what we need to do as far as surgery is concerned. This is a classical QNO segmentation of the right side anterior sector of 5 and 8, the posterior sector of 6 and 7, the segment 4 and segment 2 and 3. This is a fairly simplistic schematic diagram. But when you go to Nimura's classification, this is how the bile ducts can actually look like. Now, the importance of it is really a complex anatomy when you cannot understand. The reason being, there is an overlap of someone is
Sir, the slide is not visible. I think you have to share it again.
Okay, I'm sharing it again. Now?
Yeah, now coming.
Okay. Maybe it's possibly it's kind of dropping in between. Just let me know. Now, what I was, if you can see this diagram, when you see this, you find that segment 4A is coming down and 6 also is coming down. So the direction of the ductal system is not an indicator of where the
So this is muted.
Manash bhai, Jagannath sir को mute कर देले.
Muted. No sound is there.
Now are you okay? Can you hear me now?
Yeah, now,
Yes.
now we are hearing. Yes.
Yeah, somebody.
Again going to meet. Manash was. Manash I muted कर दी चंद्र. Manash I muted or something.
Manash bhai,
Mute कर दी
Jagannath
चंद्र.
sir को unmute करंतु.
Hitting me intentionally or unintentionally. We can no sound, no this one. So who is controlling the mute? I don't know. I'm getting muted.
Now it is okay, sir.
Now it's okay.
Yeah.
All right, fine. Now can you see the screen? You can't see the screen.
Yeah, we are seeing the screen.
Yeah. Now I'll do one thing. I'll see both the windows. Whenever I feel that there's a muting, I'll come back and I'll do it myself. So that is the thing. Second thing is that cholestasis and sepsis because of cholestasis and liver regeneration. These are the various important factors which we need to understand before we plan for surgery. Now, most important, this is the thing which I should not ever see is the prior intervention and the referral. Unfortunately for us as surgeons, we have suffered for long with a irrational intervention both by endoscopy colleagues and the radiologists in such a way that we find it extremely difficult for managing these patients. Now, this one, I'm not very sure. I don't think we need to run this poll, Manas, because all these classifications, Bismuth's classification, and then subsequently Pierre Clavian set up a group and they came out with the classification. The Sloan Kettering has a grouping, and all these people have different classifications. But let's go through one of them. Bismuth. Everybody knows about Bismuth and Corley's classification. It was wondering that, when Bismuth was there for his Living Legend lecture in Mumbai, everyone asked him this question: who is this Corley? Is somebody, some huge HPB surgeon? And you know what he said? He said she was my resident, and that's how he drew the pictures. And her classification is named after her and Bismuth. So most of the residents who are there listening to me, please understand that your name can become immortal if you only help one of the senior surgeons like me to have some kind of a contribution, and then your name is there forever. When you see a biliary ductal anatomy, you just have to decide only one thing. Is it a right dominant disease or a left dominant disease? We are now not talking about type 1, which is a subhilar tumor like this. Subhilar tumors are very easy to resect. They can just go above and do a row of anastomosis. I'm talking about 2 and 3 particularly. So is it a right dominant disease or a left dominant disease? This is the first thing you must decide. So that's about the biliary anatomy. The proximal extent is the one which is important. Distal extent is not very important. Now, Manas, if you want to run a poll, now that there is an ultrasound shows that there is a HILAR block likely, the intrahepatic ducts are dilated, and you also find that the CBD is not dilated. So you are likely to be dealing with a proximal block. So which investigation would you prefer for anatomy, biliary anatomy? Is it ERCP or is it MRCP or is it PTC? You're seeing that. Okay. Okay. All right. A, B, and C are getting distributed. I'm glad that there are a lot of B and C rather than A. Because one thing we must always remember, and those of you who feel that ERCP is the way to do biliary anatomy, please reconsider your opinion, because I'm going to show you how ERCP can actually be difficult. Now, most important thing which has happened is that we now have an excellent non-invasive technique by way of an MRCP. MRCP will give me a good information as far as the ductal dilatation is concerned. But please remember one very, very important thing. When you initially see the patient, the biliary ducts will be grossly dilated. You cannot see this kind of an anatomical features. It will be a big bunch of crowded ducts, and you are likely to miss out some of the finer details in a dilated ductal system. So please remember this, very important. So initial MRCP will only give you fair accuracy, but it is not going to be very accurate as far as staging is concerned. You can do a 3D reconstruction and you can actually play with the images. All that is fine as long as you have a raw data, which is good. But for biliary anatomy, MRCP is good, but you also need a PTBD and drainage later on. So as far as the MR is concerned, non-invasive, it is excellent. PTC, of course, there is no doubt about it. It is good. But PTC, that means only cholangiogram and not drainage, is not recommended. Your MRCP is the one which is for diagnosis. PTC will be only prior to PTBD, that is a drainage, which we come to later. Now I want to ask you one thing. You have seen the staging. You have seen that you have type 1 and type 2 and type 3 and AB. Which is this block? It looks very classically like a subhilar block. It says, oh, MRCP says it's a type 1 block. But so obviously the endoscopist thought that, okay, I need to just put a stent in one side because the hilum is communicating. So if I just put a stent in one side, the patient will have relief of jaundice. And this is what he finds on ERCP. Actually, because of the overlap of the ductal system, what was looking like a type 1 is actually type 3A block. And now we are in a lot of difficulty because you have now put in contrast in both the ductal system, and it's very difficult to kind of put in a drainage in both the ductal system at one go. And this is a classical picture which leads to cholangitis and really, really makes it difficult for the patient. So please avoid it. And how do you avoid it? I'll tell you how you can avoid it. By having an MRCP image rotated, first in the supine position where you can see, can you see my screen? You can see the supine position, the ductals there, but then rotate the entire image. You don't have to rotate the patient at this time. You can rotate the image as far as the MR is concerned. And then you can actually see the ducts can get separated. You can have a very accurate information on the type of the ductal obstruction. Not just a plain MRCP with a dilated system. You need to rotate and then get the correct imaging. Now, next question about, now we have got a ductal anatomy. We know how proximally the bile ducts are getting involved. Now comes to vascular anatomy. In a vascular anatomy, what would you prefer? Is it a triphasic CT scan, a conventional angiography, or a contrast MR? I'm so happy to see the kind of quick responses coming in. All of you will, you're cracking the MCQs in a record time. Great. Obviously, it's a triphasic CT is scoring way above the rest of the investigation, which is absolutely right. The modern triphasic CT scan is the best way for us to understand the vascular. When I say a triphasic CT scan, you must tell your radiologist that a contrast should be continuously being injected while you take the arterial, the portal venous, and the venous phase. It's not one shot of contrast and then take the pictures. No, that's not a triphasic CT scan. So that's a very good way of assessing the vascular anatomy. And again, I'm going to repeat to you, this has to be done before a stent has been put. So please insist that any patient of jaundice should have a contrast triphasic CT scan before any stent, be it a periampullary tumor or a HILAR tumor. Look at this. If this particular image is obscured by a stent there, you will have lost a very vital information. So stenting should not be done before staging of any disease. Here you can now triphasic CT scan, I always tell my residents, also has to be seen in triplanar. That means you have to do not only the axial plane, you have to study in coronal plane and the sagittal plane. All these three planes are important. See, if you see in coronal plane in this, you can very clearly say that the left portal vein is nicely filled up, whereas the right portal vein is getting blocked by tumor, which is not allowing the right here. There's a tumor there. So this is a classical way. By a coronal plane, you can study the portal vein, and you can actually see all the three planes together on a console. So please make it a habit to go to the CT scan department, work on a workstation, and not see just the printed images, because there you get a lot of information, which with due apologies to my radiology colleagues, they would not be too interested in giving you this information, because you are the one who is operating and you need to really see this information for yourself. So as far as the portal vein and the arterial involvement is concerned, yes, the real question is about the arterial involvement, where you can see that you have a slight drop of imaging, because arterial enhancement can be a little tricky, but a good contrast study is very good. Now comes a very important question, that the patient is going to have one investigation for biliary duct, which is MR, and one investigation for a vascular study, which is CT. Can we not do a good MR contrast for the vascular anatomy? I don't know about you, but so far I have not really found the kind of finer details with an MR angiography compared to a CT, but I'm sure there are good MR machines and good radiologists out there who can give you good information. So at this point, for me, a good CT is an important investigation for the vascular anatomy. Now, I want to spend a little time on this very important anatomical detail, which you must understand. When you see a hepatic artery, the hepatic artery is to the left of the bile duct, which is a normal. Left of the bile duct is the hepatic artery. And when it goes up, when the hepatic artery goes up, the right hepatic artery is given and crosses the bile duct posterior, mostly posterior to the bile duct. And what is up just above that? Above that is the hilum. So a hilar tumor classically involves the right hepatic artery, because that's the closest structure which is crossing the bile duct posteriorly. Whereas the left hepatic artery is very favorable to the surgeon. Left hepatic artery is given off earlier than the hilum, and many times it is given off even from the proper hepatic artery or even left gastric artery. So the left hepatic artery is away from the hilum, whereas the right hepatic artery crosses very close to the hilum. It is one structure which you need to really closely see when you do a CT or any kind of an angiography. If you have doubt, then that's when your conventional angiography can be done to delineate the right hepatic artery. Of course, you can always have, right in the schematic diagram, and like in this angiography, you can have a middle hepatic artery, which is supplying the segment 4. So you do have variations. The variation which is very important for us is, of course, the left hepatic artery coming from the left gastric, which is a favorable variation. And that the more difficult variation is, of course, the common hepatic or the right hepatic artery coming from the SMA, which then travels to the right of the bile duct, and that's where it can really get important tumor. Now, the next important point on the CT scan. Anytime you can't see my slides, I'll reshare the slides. Don't worry.
Yeah, the slides are not visible. Yeah, no.
Not visible?
No.
Manash, no.
Okay, fine. We start again. Resume. Okay. Now is it visible?
Not yet.
No.
Not yet. I think we should complain to Google that they are charging they're charging us for not a good product. Now I'll reshare it again. Now are we okay?
Not yet.
Now it is
Yes.
Just give it a little time. It'll buffer and then give it. Okay, can you see now?
Yes.
Yeah. Now this is a good CT scan because it's nicely contrast is there. And I really want you to see some very interesting findings. One is that you find that the ducts are dilated on the left lobe of the liver, right? Okay, ducts are dilated. And you find that in this particular first upper scan, there's a kind of a demarcation line going along from the inferior vena cava up, as though that this side is darker and that side is brightly lit up. This is differential perfusion of the liver. And what happens in this case, when you see the portal venous study, you find that the left portal vein is not getting visualized. The lobar atrophy indicates a portal venous involvement, very important. And the dilated ducts in an atrophic lobe does not mean that now those ducts are functional. Because the lobar atrophy is there, because of portal venous involvement, the ducts look bigger. And that's an important finding you must always look for in a CT scan. Is there a lobar atrophy? Because lobar atrophy signifies a portal venous involvement. Because the portal vein gets, when a lobar atrophy happens, there's a compensatory hypertrophy on the other side. In this particular MR picture, you can see that there is a ductal, there's a blockage here. So the right-sided segmental atrophy is there. And what has happened is the left side of the liver, segment 2 and 3, have become hypertrophic. What it actually produces, which Professor Blumgart has described, is a rotation of the liver. That means the left lobe of the liver starts becoming bigger and the right lobe starts shrinking, and there is a rotation of the axis of the liver. So please look for a lobar atrophy, which is an indicator of a portal venous involvement of that particular lobe or even that particular sector of the liver. Very important for us. Now, how do you evaluate for resection? Bismuth classification is only giving me a biliary ductal anatomy. It doesn't give me any roadmap for resection. That's where the Memorial Sloan Kettering grouping comes very, very, very important. Now, what is the first T1 kind of a disease is that first order ducts, that means it's the bifurcation going on to one of the sides, but not to the sectoral duct, is the T1 staging according to them. T2 is, yes, the ducts are involved up to second order ducts, which also produces the kind of a tumor extension along the ducts, which is very, very common in the HILAR cholangiocarcinoma. But there is no contralateral involvement. T2 always also means that, okay, there is an involvement of the, not only the second order ducts, but there could be a segmental involvement of the portal vein, which is also still a fairly resectable situation. When you go further advanced, then you find that there is a bilobar ductal involvement or a ductal involvement on one side and a portal venous involvement on the other side. Now things start becoming complicated because if it is one-sided, it is much easier. But if it is bilateral involvement or contralateral involvement, then it starts becoming more and more difficult, challenging-wise, as far as surgery is concerned. So involvement of ducts on one side and ipsilateral vascular involvement is perfect, but involvement of ducts on one side and a contralateral vascular involvement is more difficult to handle. Once you know the anatomical extent of both the bile ducts and the vascular structures, next question is the liver. The liver is very, very important because now we have understood after initial experience that liver resection is necessary to get a negative margin for all type 3 tumors. So literally almost every HILAR cholangiocarcinoma, you must plan for a liver resection. The second question you have to ask is that, is there a cholangitis? Why does cholangitis happen? Cholangitis happens because there can be a contrast injection, as I showed you earlier, in an obstructed liver, is one very common cause. Second thing, cholangitis can happen even otherwise also in an obstructed biliary system. It is classically, it is with fever and chills. And let me tell you one thing, cholangitis is one of the worst infections it is really, really bad. Patient can go down in a matter of hours with cholangitis. Liver status can also be bad because of earlier fatty livers, which are now very common, alcohol intake, etc. And we need to do a CT volumetry because your CT scan also should have a CT volumetry. So this is what is important as far as functional status of liver. Yes, you might say, what about ICG? Yes, ICG is something which is so commonly used in Japan. I really wonder why we are using ICG for vascularity in laparoscopic surgery, and the same ICG is not very commonly used for liver surgery. So I think this is one area where the liver surgeons should really start using ICG a lot more frequently than we are doing now. Very, very important. Now let's talk about irresectability. One, of course, is the patient factors, that non-fit patient, portal hypertension, very difficult to do any liver resection. The local factors are ipsilateral portal vein involvement, no issue, but a contralateral portal vein involvement, also it is possible if you do a portal venous anastomosis, but an arterial involvement contralateral is really difficult. And arterial reconstructions in a HILAR cholangiocarcinoma are really difficult because the arteries become much smaller when it go into the liver and start bifurcating. So it's really difficult to get a good arterial anastomosis. When there is distant disease, obviously we are not going to resect. It is very important to note this very early in your staging algorithm. One thing I want to categorically tell you is that preoperative histology is not necessary. Don't struggle for that. Yes, you will have the US chap saying that we're going to do an endoscopic ultrasound and do a biopsy of the hilum. Let's forget about it. Don't even do it. You might have a small percentage of sclerosing cholangitis or IgG4 associated disease, but they can be detected in an MRCP with segmental narrowing. So that is a different thing altogether. Otherwise, do not struggle for a diagnosis. The same thing with PTBD. You can do a brushing, but if the brushings can become negative, because most of these tumors are sclerosing tumors, do not struggle for a diagnosis because most of the HILAR tumors are malignant. Even if they are not malignant, a HILAR stricture has to be treated with a good resection and a drainage. Otherwise, recurrent cholangitis is going to be a problem. Now comes a very important question of preoperative biliary drainage. We have to remember that cholestatic liver is very dangerous to resect. So it's very important to provide biliary drainage to ensure that the cholestasis gets reversed. Nutritionally, the patient gets better. While I constantly urge people to resect periampule low bile duct tumors without drainage, when it comes to hepatic resections, I am erring more on preoperative biliary drainage, except a few cases, which I'll tell you. So if you have to do a preoperative biliary drainage, what kind of a drainage would you now prefer? Is it a ERCP stenting, or is it PTBD, or the new investigation of nasobiliary drainage? Oh, that's good. Rapid responses as far as PTBD is concerned, which is fine. Some NBDs, yes, okay. But I'm so glad that ERCP and stenting is not coming up as one of the ways of drainage of preoperatively. The reason is very, very simple. I'll show you in the next slide as to why ERCP stenting is not feasible. Before that, I just have to spend a little time on the preoperative drainage. Now, the questions we have to ask is when to drain. Obviously, after the staging CT scan and MRCP, before liver resection. If there's a cholangitis, segmental cholangitis, just go for drainage. PTBD is what we prefer. Now, what do you drain is an important question. Is it a right or left or both? Most important thing we have to see is that you have to drain the remnant liver, which is important. What liver which you're going to leave behind is what you're going to drain. If there's an atrophic lobe, there is no point in draining there because that's not going to be functional unless there is cholangitis. So you're going to drain the liver which you're going to leave behind. And if that doesn't improve the jaundice, you're also going to drain the opposite side. Typically, sometimes the patient will have 3 drains, one in the left side and 2 drains, one in the anterior sector of the right side and posterior sector of the right side. So this is typically how the patient will have drainage. So pre-operative biliary drainage is a Nagoya school, which has been very well accepted throughout the world, but they also had problems. Jack Belgetti, you know very well, that is another great proponent of pre-operative drainage. But what is very, very distressing for us is to have multiple endoscopic drainage, which is really going to make our things very difficult. The PTBD drainage, you must tell your radiologist, is not to put thick drains and not to put them proximal. They have to do a peripheral drainage. In fact, in Japan, surgeons do PTBDs because they inject, they puncture peripherally and leave a small caliber drain to drain the bile. I somehow get a feeling that our IR people, with apologies, are not that careful, and they try to sometimes hit so close to the portal vein that you find it very difficult to dissect it during surgery. This is how endoscopic biliary drainage works. And there's an anatomical reason for it. If you see the segmental anatomy, the classical segmental anatomy, the bile duct, which is in the direct line for the common bile duct, is segment 8 duct. So when an endoscopist puts a guide wire, it straight walks into the anterior sector, segment 8 duct, and his stent invariably goes there and sits there into the segment, into the anterior sector, segment 8 duct of the right lobe. And what happens to the left lobe? Doesn't get drained because there's an acute bend on the left side, which is difficult for them to take. So very easy for them to put a drain into segment 8 duct and leaving the rest of the bile duct injected with contrast and leading to cholangitis. So please, for heaven's sake, don't do this. Now, when you want to stage, you have done the staging and now you are getting ready for going to the next step. So you need to do some staging maneuvers. One is, of course, well, is it nodal spread is there or not? I must tell you categorically that involvement of the porta-hepatic nodes is not a contraindication for surgery for hilar cholangiocarcinoma.
Yeah.
But more proximal nodes, suppose you have a PET scan might be useful, not always mandatory unless you have big nodes on a CT scan. So if you have nodes, even the gastrohepatic ligament and along the hepatic artery, they can be comfortably resected, no issue at all. So don't make them irresectable. The laparoscopy is an important investigation because you have now realized that your patient has undergone MRCP, CT scan, PTBD. Now, before you go in further, you have to ensure that there are no peritoneal metastases. So you can in a type 3 where you're going to plan an extended resections, you might do a laparoscopy just to make sure that later on this patient should not have a peritoneal disease. So that's one thing. Apart from that, laparoscopy on a regular basis has not too much of a role in hilar cholangiocarcinoma. The surgical principles are bile duct resection, radical surgery. The duct has to be dissected almost up to the pancreatic head. And the proximal resection is determined by what we have determined, that is it a right dominant disease or a left dominant disease. That means your plan of hepatic resection is pre-operatively determined. There is nothing like intraoperatively, I'm going to say, I'm going to do a left hepatectomy or right hepatectomy. No, everything is done pre-operatively. Ductal margin should be grossly negative. That's all. It has to be grossly negative. Do not again sweat with a frozen section. Hepatic resections are necessary. So you are going to do two types of resections. The most common thing is a right trisegmentectomy. That is, entire right lobe is segment 4. This is the most common surgery which you can do for hilar cholangiocarcinoma. I'll come to the reason why you need to do it. Left resections of left lobectomy can be done, provided it's only a segment 2 and 3 ducts with left portal vein involvement. It can be done, but there are also an important, like the scan which I showed you, where left lobar atrophy, yes, a left hepatectomy can comfortably be done. For left trisegmentectomy, it's a complex procedure. People with experience with the right hepatic arterial anastomosis might attempt it, but it is a complex procedure. So the right trisegmentectomy, fairly standard and a good procedure, provided you have a right ductal involvement. Caudate lobe is a posterior bed, as I told you, and it is very important to resect the caudate lobe because that is the posterior limit of the hilum, and it has to be resected along with the specimen for either right or left hepatectomy. Very important. Chordate lobar ducts are involved early in hilar cholangiocarcinoma. Lymphadenectomy can comfortably be done. Most of the lymphadenectomy is right up to the celiac. But if it is a para-aortic nodal involvement, obviously these patients are not suitable for surgery. Otherwise, hilar, portal, common hepatic artery, going right up to the posterior pancreatic, all these nodes can be comfortably resected. Now about the margins. Earlier on, we used to be very kind of finicky about margins. But now we realize that margins are difficult, both for the pathologists and also for the surgeons. So the best thing is to have a long margin. So that is what is important, that a left hepatic duct, you know very well, enters the hilum at the round ligament fissure. So if you can really get a good length of the left hepatic duct, you will get a good margin. We do not, and we have stopped doing frozen sections in these patients. Yes, you might have a microscopic margin in the final specimen, but that's fine. That's still fine. Your aim is to have a gross negative margins and not a microscopic negative margins. If you take a good margin of more than 5 millimeters, these tumors, unless they are papillary tumors, or do not spread well, do not spread too much. So you can do a negative, you can get a negative final margin if you get more than 5 millimeter wide margin. That's the reason why extended right hepatectomy is a procedure of choice. There is no doubt that survival depends completely on the resection. And that's the reason why aggressive surgery is very, very important for these tumors. And we need more groups to do this surgery. If you start doing these surgeries, you'll find that you're getting survivals, a good number of survivals, and people have gone with large series. Now the Nagino series is more than 200 patients, and they do have long survival. So this is the best option for the patients. I'll tell you another thing is that if we do not resect the patients, it's not as though the patients will die soon. And this is a miserable progress as far as these patients are concerned. They get repeated cholangitis, stent blockages. They keep on coming to the hospitals. Metal stents are really difficult to change, and they have multiple episodes of sepsis. So their quality of life, if non-resectable tumors, are really poor. So make all the attempts to resect these tumors, and that is actually, even if they live for a shorter period of time, they will certainly be much better off. Clavian has kind of Clavian has proposed this. Clavian normally brings together a few people and proposes classification. So you have Clavian Dindo for infections and etc. etc. I must say that this classification is really not taken on very well. So the age-old bismuth as well as memorial stone catering is the one which is largely followed by people. Now there are some important shifts in the management. What if we don't drain? What if we don't drain? Don't do biliary drainage? Yes. Any problem? Hello? Any problem? Any problem? No? Okay. If there is a patient with a lobar atrophy, like the one I showed you, the left lobe portal vein is involved, left lobar atrophy is there. If you have noted carefully, the right ductal system is not much dilated, the bilirubin is less, then you can resect without having a biliary drainage. So this is something which is important. There are patients whom can be resected without biliary drainage, provided there is no cholangitis and there is adequate remnant liver volume. You can, particularly the left resections, can be done without biliary drainage. The second thing what the Nagoya group has found is that there is the seeding of the tumor along the track of PTBD, and that's the reason why they went into endoscopic nasobiliary drainage. But having said that, the endoscopic nasobiliary drainage is largely done in Japan, because patients are fairly comfortable in having 1 or 2 tubes in the nose. We don't have the kind of patient compliance nor the expertise to have this kind of multiple endoscopic biliary drainage or 2 of them in right and left lobes. So this is something which has not been explored by us. We continue to have the PTBDs. The secret is that you should not put in large tubes, and maybe you need to get the tubes out early and then go in for surgery. So normally the Japanese leave their tubes for almost a couple of months, which may be a little too long, but we can go in for surgery as soon as the bilirubin starts normalizing. Now, I was telling you about this case that there is a left lobar crowding, left portal vein is involved, artery is involved on the left side. So these patients, when there's no dilatation, you can go in for a left hepatectomy without doing a biliary drainage. So if you really see our pathway normally, of course, ultrasound and Doppler is fine, MRCP and a triphasic CT scan. Type 1 and 2 are resectable. It can go in for, without drainage, you can go in for surgery. Type 3 is, I would say, selective PTBD. Then you do a volumetry and a portal vein enhancement. And then if it is resectable, go for a hepatectomy. Unresectable, you go for palliation with metal stenting. I just want to take you through one case we've managed, and you can see different aspects of it. Typical patient with a jaundice and bilirubin is high. CA19, please remember, is not a great marker. So you don't have to really bother about CA19, gets elevated in jaundice. And as we have rightly said, that the investigation of choice would be a triphasic CT scan and an MR. This is the triphasic scan. And I want the residents to note very carefully that there's a mass lesion here at the base of segment 4, very close to the portal vein. Though the portal vein seems to be normal, but the middle hepatic artery, that is, you have the middle artery which is going to segment 4, is involved. So you do have an arterial involvement, though the portal vein looks fairly okay. So is it resectable according to you or not resectable? If it is resectable, just say A. If it is not resectable, say B. Good. Good. Lot of good surgeons there. Aggressive guys. Very good. Excellent. So all of you say that, okay, I want to resect this patient, right? Now, what are the features which are really, really important is that it is close to the right portal vein. And very important, there are some features which you must always understand that easier for the surgeon, that left hepatic artery is coming from left gastric artery. That means this left hepatic artery is going to be away from our field, and the left portal vein is patent. But our main problem here is, of course, it's close to the right portal vein and the middle artery is involved. When you see the ductal anatomy in this particular case on an MRCP, you find what is it? Is it a right dominant disease or a left dominant disease? If it is a right dominant disease, say A. If it is a left dominant disease, say B. Now let's see how much has been picked up. Right dominant disease is A, left dominant is B. Okay, there is one B coming up. Okay, another B. Right dominant is A, left dominant is B. When you say dominant disease, what I would ask you to see is that is there a secondary sectoral involvement on that particular side? In this particular section, you find that right anterior sector, which is here, posterior sector, the narrowing is extending right up there, right up here. And also, it is a left hepatic duct which is free. And segment 4 duct is okay. Segment 2 and 3 are fine. But anterior sectoral duct on the right side and posterior sectoral duct on the right side are again involved. So this is a right dominant disease. At the same time, we also find in an arterial study that the middle hepatic artery which supplies the segment 4 is also involved. So this particular patient, what kind of a resection would we have? He will need an extended right hepatectomy, because not only the right lobe is involved because of ductal anatomy and arterial involvement of the segment 4, so he'll need extended right hepatectomy. But because the left hepatic duct is free here, we find that we are going to get a good margin in this particular case by a extended right hepatectomy. So what next? ERCP and stenting, PTBD, NBD. I think we are fairly clear, but I'll just ask you about this. Which side do you want to drain, right side or left side? Very good. Very good. Because we are going to preserve the left side, you will see that left drainage is better. But if the patient has cholangitis, you may have to do more than one tube, which is fine with us. But yes, drainage is important, because now we are planning an extended right hepatectomy, a large surgery, right? Now PTBD was done, cholangitis subsided, patient improved, bilirubin has come down. Now now you can see the difference. How much of information is there, additional information on even on a cholangiogram. You see the narrowing starting right from the hilum, going all into the hepatic ducts inside on the right side. And look, now you realize that yes, the segment 4 duct is likely to be involved, whereas 2 and 3 is likely to be free. So our plan of resection of a right trisegmentectomy is correct. This is what we need to see. But what's the next question which we need to ask now? Is to see, is the left lateral segment of 2 and 3, is it sufficient volume or not? So you need to do a volumetry, because we know that we are doing a resection of a large segment of the large volume of the liver, and volume is okay or not is what we need to check on a multiple software which is there available now. Now that, as we expected, the future remnant liver is low with 22%. So it's a low FLR. Do you want to resect now or you don't want to resect now? A is yes, B is no. No. Amazing, guys. You are absolutely, you're like tomorrow, your HILAR cholangiocarcinoma comes, you just go and then operate. That's it. Very good. So we can't operate on this patient because the FLR is low. So what do? We have to do a right portal embolization. Now, when you see a right portal embolization, there are all these multiple coils. You have to do not just the main vessels. You have to do multiple vessels, because there are many intrahepatic portal connections. So you need to really go and then meticulously block the vessels. One important point is that, do you want to block the segment 4 portal vein or not, is the one big question. Now, this is a complex question. Now, because you're all expert, A is, I want to block the segment 4 portal vein because I want to get more volume. B, I don't want to block the segment 4 vein because it is very risky. I might block the left portal vein also. It's a mixed bag. I am a little conservative, or at least your radiologist should be. If he is really good, he will be able to block the segment 4. But by chance, if he puts a coil in the left portal vein, end of the story. So this is we elected to do a right portal vein embolization. You can always come back if we find that the volume is not sufficient. You can always do a further blockage of segment 4, but it has to be a little more carefully done. So 3 weeks later, sometimes you can even wait for 4 weeks. The FLR has increased to 34%, fairly okay. I would have been much better if it is higher, but it's fine. So procedure, we have already decided it's going to be extended right hepatectomy with a caudate lobectomy. Fairly major procedure, and you're going to take the whole day. So that is what is necessary, extended hepatectomy with a caudate lobectomy. So fortunately, because we are able to pre-operatively optimize this patient, and once the anastomosis is fairly well done, the patient would recover well. So I am not very sure I should show this video, but let me see. It's a very short video. Procedure takes 10 hours. We are now putting it in 1.5 minutes. Okay, I think I've lost it. Let me see if I can. That's left hepatic artery, which is going which is going into round ligament fissure. So we are very happy that we are away from the hilum. That's the cystic duct and bile duct. We have blocked the right portal vein, so we are pretty happy. It's not going to bleed. So I just need to make sure that left portal vein is intact. The arterial twig, we have blocked only right portal vein. We have not blocked the right artery. So this is the right artery which is being picked up. But as I told you, it goes behind the hilum. So we need to make sure that we ligate the right hepatic artery which is traveling behind the hilum. So that's about the vascular structure we need to identify and ligate. We can, in fact, the first step literally is to ligate out the bile duct low down and then lift it up. Only when you ligate the bile duct low down and lift it up, that you get the access to the portal vein. And of course, you remove all these lymph nodes from there, send them off. But as I told you, even a positive node does not mean that you should stop resecting when the nodes are around the hilum. Oh, suddenly they jumped onto the liver split. Are we coming back? Okay, we have split the bridge between segment 2-3 and segment 4 so that you get a more space. And now we are working on to the right of the round ligament to ligate this portal branches going onto the segment 4. And then after that, once you go deeper, then you will get the middle vein, which we need to staple it off. So we use what's called the focus clysis, which is a combination of Kelly clysis with focus. When you go down, your middle hepatic vein is the one which you need to ligate. Sometimes you may have to do an extra hepatic ligation of the right hepatic vein, which is fine. But largely, middle hepatic vein is done inside. And as we go down further, the caudate lobe is out. I know it looks very simple. That's not simple. You will have the left plateal segment. You will have the left portal vein, and you will have this sometimes one and sometimes even two ducts. And that's the segment 2-3. Sonography is intraoperative sono is very critical. You can see the good flow there going onto the liver, which is pretty happy. Hitch up the liver, and the anastomosis is normally done with a 4-row interrupted PDS sutures. It's a fairly straightforward anastomosis, interrupted PDS sutures to a rule loop of jejunum, and you are done. But this takes about good period of time. Let me just move on to the next one. Now, what is not to be done is this metal stenting. So this is something which is, I told you that we should never do middle stent. We struggled to do these surgeries earlier on with severe amount of fibrotic reaction all around the metal stent. At that time, I was much younger, so we did these resections. But when I showed this picture to Professor Nimura, he said, no, don't do this, because he feels that doing a metal stent means it is not resectable. Unfortunately for us, in this particular patient, there are 2 metal stents, endoscopically, PTBD, and 1 more tube. This is going to be our norm, our unfortunate reality. So many times, like in Whipple's, you might have to operate with metal stents, but that's going to make it at least 4x more difficult than the usual unstented patient. But that's it. But avoid this if possible with your team. So to make it close this now, very good preoperative evaluation. That's the most important thing. And prepare with control the cholangitis, increase the volume, and then you can go for a safe resection. What we really need, I see that many of you have done some fabulous answers. Really, really very happy. You all need to be in HPB centers. You want to start HPB centers. And we have to do more cholangiocarcinomas in this country, more gallbladder cancer surgeries in this country. Otherwise, we'll be just doing some usual small surgeries. This is really a challenging surgery. And start getting these teams together. Team approach is very essential. Your IR, your hepatologists or your physicians are very important. And if you get a team, then you can actually refer to such center. I'll just end with this quote: the strength of the team is that of individual member, and the strength of individual member is that of the team. So if you have a good team, you will find that everyone will step it up: a good radiologist, a good IR, a good physician and ICU person, and of course you as a good surgeon can lead this team. It is such a pleasure to share these thoughts with you. I'm sure it'll come to it'll stimulate you. I have some areas I have not covered, like Nyhaus no touch technique, liver transplantation, as someone was asking, but these are all still small series and they have not been widely accepted. So that's where we stop and take some queries if they are there.
Hello.
Yeah.
So, Manas, we can share now. Yeah.
Manas, I can't hear you. Yeah, now you're on.
You're still muted.
Muted.
But Manas, we are not hearing you.
Yeah, what's your opinion about vascular resection? Yes, certainly it can be done. And the best of course is left-sided left portal vein is a longer course extrahepatic. So the best option is to when you're doing a right segment, you can resect the portal bifurcation and anastomose the left portal vein. So that's a best case scenario as far as the portal venous resection is concerned.
There's another one controversy.
Yeah.
Like you're telling this, the microscopic margin positivity is not a major issue.
Yeah.
This is always there. But simultaneously, the margin negative that affects the survival.
Correct.
That decision that is actually crucial. That suppose someone is putting the metallic stent.
Yeah.
Then some neoadjuvant received and responded well. The disease is there. So what is the point of view that we can go and resect it and it is possible that we are pull out this metallic stent and the margin positivity controversy is still there?
No, you're right. See, once you put a stent, normally an unstented biliary system, you can actually feel the thickening and you can plan your resection. But once a stent is put, there's so much of fibrosis that you find it difficult to make out if it is fibrosis or disease. What I found out in what I recognized is all the patients with stents, all those with even microscopic margin positivity have actually done better. Yes, they did have problems in the longer run, but those who have not had resections, it has been a really they don't have metastatic disease. It doesn't spread widely, and they really have a miserable course. So I've really kind of come to this solution that 14 months of fairly symptom-free survival is fair enough.
Yeah.
Rather than 6 months of repeated hospitalization and cholangitis.
So why I raise this issue, at times we are getting already stented patients.
I know.
That is the issue. We can go ahead and resect it.
Yeah. I think you should go ahead and resect these patients. Be guided by the pre-stenting MRCP. If these people only do an MR and a CT before stenting, let them put whatever stent they want. You can actually do the surgery based on the pre-stenting MR and give a good wide resection, and that's about the best you can do.
That is a good thing.
Yeah.
And at times that is involving like vascular things short segment, we can resect and reconstruct. This is the another point.
You can resect, particularly the left portal vein. It can be easily mobilized. You can resect and then re-anastomose. Is not an issue at all. One thing I have to tell you is that the bile duct is the last one. If you have, say, for example, you want to resect the portal bifurcation, you have a vascular clamp on the left portal vein and the main portal vein, resect it out, re-anastomose, let the liver be perfused while you do the liver split. Nowadays, we don't do any kind of Pringle at all. We allow the liver to be perfused and divide the bile duct last. That's the best thing to do. Portal vein anastomosis should be fairly standard. Arterial anastomosis is where we get into problems because it needs either a good plastic microvascular surgeon. So that's an issue which we have not been able to address. Not many groups in the world have been able to address that. Neoadjuvant therapy in a HILAR cholangiocarcinoma, no neoadjuvant therapy, because these patients are already they're sick. They're having multiple issues. You put them on a cholestatic liver through chemotherapy will be another issue. This is not gallbladder cancer where neoadjuvant might be useful. This is HILAR tumors are different. So I would not give them.
Neoadjuvant also response is not so good like other hepatobiliary.
So no neoadjuvant therapy for HILAR cholangiocarcinoma. Anything else?
Another point that you were raised, this is like nodal involvement. This is like,
I'm quite happy to dissect out all the nodes in the gastrohepatic ligament along the hepatic artery. I have a video of that.
So what is the extent of nodal dissection? You go and
I go see like how you do Vipuls. You go along the hepatic artery. Hepatic artery turns down the celiac artery. That's where you can go up to that level comfortably. So all along the hepatic artery, on the proper hepatic artery, up to the celiac artery. And also when you lift up when you cockroach the duodenum, you'll find one node at the lower end of the bile duct that also can be removed. But if you go into pyrotic nodes, I would not go in for resection. But that would be hopefully be staged pre-operatively by a PET scan. Yes.
Hello. Good evening. Can I ask one question?
Yeah, sure.
Sir, what is the role of ALPS in this era? And if you have to go for ALPS, then how do you select the patient?
The same question was asked, during when Edward Santibanus was presenting about ALPS. See, the problem about ALPS is how is ALPS different from a good portal vein embolization? I'm still not convinced. If you have a good portal embolization, please understand one thing. These patients are sick. They have tubes. They have cholangitis. So they are not like colorectal metastasis where you do an ALPS, liver goes, and then you go in for resection. These patients, if they have had a good portal embolization, will have a good volume enhancement. And that is one surgery and then out. Unlike the colorectal metastasis, where ALPS may have some role, in HILAR cholangiocarcinoma, ALPS will have limited role. Because finally, you just want to enhance the liver volume.
So, do you send cut surface margin bile duct for frozen section for each?
No. As I told you, we have stopped doing frozen sections because number one, it's very difficult for the pathologists also to comment on frozen because they're very, very narrow, small this thing. So you have to feel it, and you can easily feel a normal duct and an abnormal duct. And then if you go in for a normal duct and then resect out, see, your limit of resection is an umbilical fissure. Till then, you can go as far left the hepatic duct is concerned. So up to that margin, you go and then you resect out the left duct, and that's it. That's about maximum you can do. So I don't send a frozen section with a clear this thing that there can be a microscopic margin positive. Actually, one more thing I must tell you. The pathologists have to be actually shown about grossing the disease. They would not know what are the ductal margins. You have to go there and mark the ductal margins. Otherwise, they will not be able to find out which are the ductal margins. So on that count, I would take out the ductal margins separately and say that this is the distal ductal margin. as for, I mean, proximal ductal margin kind of. That's about that. But I don't do frozen sections. So that is no. There's one more question which was about Mayo Clinic approach of transplantation. So that's a very small. It is there, but I feel it's a logistic exercise which is going to be difficult for our country, where we are really struggling with the transplants which are needed for a lot more critically ill patients. So I would not put transplant as an option. Most of when you have a good resection team, I think it's a very good option. So I think we are resecting much less than what we should be resecting, honestly speaking. Possibly because the metal stents are being put, patient is left off, and then it doesn't even get referred to a surgeon. That's the biggest problem.
This is only one point another. Suppose some vascular anomaly is there, it affects your nodal clearance.
Yeah, it does affect your. In
Like
fact, this is something which is very true. If the right hepatic artery is coming from SMA, it is on the right of the bile duct. You have to be very careful, both in Whipple's, both in this one, anywhere, because you need to preserve the artery. So that does affect the nodal clearance, but knowing it preoperatively is very important, because then at least you're prepared that there is an artery there and you can feel the pulsations and you can work above it. In fact, the last Whipple's we did, an artery coming from the SMA, which gave us a lot of trouble because it was going through the nodal mass, and that to preserve that artery, we really had to struggle. So yes, it does create problems. You're right, very right. Okay.
Sir,
Yes,
you did you feel any difficulty in dissecting the metallic stent? So then how did you overcome that? And
see, metal stent, distally you have to pull it out of the bile duct, and proximally you just leave it. It is difficult. It is painful. It's very, very painful. So, only hold wire by wire and pull it out. It's a very painful process. Very painful. Hopefully, the proximal end of the stent is not going into the resection margin. Distally, you can take it out. Distally, you just pull it out, pull out the wires. But it's really painful, and the kind of reaction it produces is tremendous. The suture preference is 4O PDS. Bile replacement and refeeding. See, this is what the Japan is does it, that they ask they filter, and then they ask the patients to drink the bile. I don't know. Our people, they just refuse to drink. You have to be Japanese to drink bile. It's not easy. Indians, that's a problem. Arterial embolization, arterial embolization has very limited role in HILAR cholangio. It may have a role in HCC, but not in HILAR cholangio. Yeah. Okay, Manas. Thank you once again, everybody, and thanks for all the discussion. I hope this format is you like this format, because we can be seeing each other. It's good for us also, and then good also to have a really good feedback and good responses from the audience. So look forward again. Hopefully next week. Yes, I want to log in to see what is happening in other fields, which is also interesting. I'm sure. Once again, Manas, congratulations for this activity. Do keep it up, and I'm sure it'll be a regular feature. Right? Even after the pandemic is over, we can really have it. Okay? Okay. Good night, everybody. Good night, everybody. Yeah. Thank you so much.
Thank you so much, sir. Thank you so much.
Good night, sir.
So this is Dr. Madhav.
What I'll do is the videos are long. I'll kind of put it in a Google Drive or somewhere. Then Manas can have an offline access to the videos. Okay. Right.
रुद्रवंश
କଣ ମାନସ ଭାଇ କୁଆଡେ ଗଲା?
ମାନସ ଭାଇ ଗାୟବ ହେଇଯାଇଛି ମଝିରେ।
ସେଇଆ କହୁଛି ପରା, ମୁଁ କହିଲି
ତାର ଦି ତିନିଟା ଖୋଲି ଦେଇଛି ବୋଧେ, ସେଇଥିରେ ପ୍ରୋବ୍ଲେମ ହେଇଛି।
ନାଇଁ ତା ଇଣ୍ଟରନେଟ ପ୍ରୋବ୍ଲେମ ଅଛି।
ହଁ, ଦିଟା ଜାଗାରେ ଖୋଲି ଦେଇଛି।
ଠିକ ଅଛି, नो प्रॉब्लम, नो प्रॉब्लम।
This was a good presentation.
बढ़िया प्रेजेंट,
Fantastic. Yeah.
मैंने बहुत बढ़िया।
That with legendary figures and interpreting in between. That's a good. Yeah.
नहीं, that was very nice. ठीक
What
है,
he
आओ।
discussed.
Good night, good night everybody. Good night. Okay.
Good night.
Am I audible now? କିଛି ଶୁଭୁନି, ପଳେଇଲେଣି ବୋଧେ ସବୁ। Am I audible? ତତେ ଶୁଭୁଛି ନା କାହାକୁ? I think it's okay. Okay, fine. ସରିଗଲାଣି ନାଇଁ, ଯିଏ ଯାହାର ଗଲେଣି।